All right, welcome back, everybody. Dr. Ash here. We are going to wrap up the basics of perfusion. And so, as promised, this last little bit is going to be about medications, everybody's favorite part. So, let's talk about the common medications that are ordered for perfusion related concepts. So, first of all, let's talk about vasodilators. Vasodilators are important in blood pressure. So, what they do is they dilate or they increase the diameter or the size of the vessel. And so it's just opening those vessels up. And the whole purpose of this is to lower cardiac output and therefore reduce blood pressure, right? Because if we are trying to push through a narrow hole, it's going to cause the blood pressure to go up, right? It's going to cause more pressure to get through that smaller hole, if you will, versus a bigger hole. So you can imagine like trying to drink through a coffee stirrer versus trying to drink through a regular straw. And so vasodilators just kind of open up to that straw size. And they do this a number of different ways. And I've listed several out here for you. For your purposes of your hypertension, the majority of what nursing school is going to ask you are going to be these top three that I have in red. Okay, the general rule of thumb is that nursing school really doesn't want you to know everything. It sounds like they do, but they don't, because the top signs and symptoms, it's usually the top four that are listed in a test question. When it comes to medications, they typically are going to ask you the big 1, 2, or 3, first or second drug. In this instance, I would go with classifications. So angiotensin converting enzyme or ACE inhibitors, the ARBs, and the beta blockers. Those are kind of your top three classifications, if you will. And we are going to talk about them individually here in just a minute. But those are your main ones for hypertension. Now, the potassium channel activators, calcium channel blockers, smooth muscle relaxants, those come in into play into different varieties. And so really we save the calcium channel blockers for pulmonary hypertension, which is not something basic. That's more of an advanced concept that we'll talk about in later perfusion as we move up in the perfusion rankings. The smooth muscle relaxants really are more of your IV kinds of medications, and the potassium channel activators as well. So let's talk about the most common. So we have the ACEs, the ARBs, and the beta blockers. And so ACEs, just like the name says, angiotensin converting enzyme inhibitor. So it blocks that enzyme from converting angiotensin 1 to angiotensin 2. Welcome back to ANP. But these are your prils. They all end in PRIL, lisinopril, enalapril, benazepril. Once you start finding the similarities in drugs, they become much easier to recognize and remember. And so your most common side effects that come along with your ACE inhibitors is a dry hacking cough. That is the most complained about, the most annoying type of symptom that a patient can experience with an ACE inhibitor. The other thing that happens with ACE inhibitors is they actually block the excretion of potassium. Therefore, they are at higher risk for hyperkalemia, so higher potassium, and of course, dizziness and headache. Now, I didn't say this at the beginning, but all three of these are for blood pressure. So remember, your number one symptom or side effect or intended effect, if you will, is going to be hypotension. So we always run the risk of hypotension. Now, it's very important in ACE inhibitors because these prils tend to have what's called a first dose hypotension effect, which means they're very potent and they start to work right away. And so what you will find is that nursing tests, right? We love to ask you about safety. So be on the lookout for that patient that just got one of the prils, captopril, lisinopril, any of the prils. They got that pril and now they're dizzy when they stand up, and so they need help to the bathroom. So just be on the lookout for that. The other thing with ACE inhibitors is it frequently causes angioedema, which is swelling of the face, tongue, neck. It can turn into an airway issue. Not super common to the point where it might be tested on in your first or second level or first couple of semesters, but definitely that's something to keep in the back of your mind, especially if you're going to talk about the concept of immunity at all. because it is an immune response. So then we move on to our ARBs, and that's that angiotensin receptor blocker. So the body can't absorb the angiotensin. And these are your sartans, losartan, valsartan. There are a couple of other ones as well, but sartan, SARTAN is what you find at the end of their names. And so again, common symptoms, dizziness, headache, and fatigue. Fatigue is very common in any of these, especially at the beginning of therapy, because what happens is the body gets used to a certain level of blood pressure and the body accommodates for that blood pressure. And so when we turn around and we drop it significantly with the use of one of these medications, we find that the patient gets very tired, as you can imagine. Lastly, we're going to talk about the beta blockers. These actually block the effects of epinephrine, which lowers heart rate and decreases the force of contraction. So it like decreases the amount of force or pumping that the heart has to do. So it actually decreases cardiac workload. And these are our OLOLs, or our laugh out louds. So these are metoprolol, atenolol, anything that ends in OLOL. Both or the beta blockers will decrease not only blood pressure, but heart rate as well. These patients tend to have, again, fatigue, dizziness, cold hands, cold feet. Typically prior to administering one of these beta blockers, you want to make sure that their pulse is above 60, their systolic blood pressure is above at least 90, if not 100. Sometimes that's standardized depending on the facility that you're at. And then the other thing with beta blockers is a lot of people don't realize that we also have beta receptor cells in our lungs. And so sometimes these beta blockers, not all of them, but some of them, tend to also cause bronchoconstriction. So we have to be very careful with the use of our LOLs in our asthma patients, our COPD patients, anybody that has kind of upper airway swelling, if you will. We'll move on to the vasopressors, and these actually press the vessels. And what happens is it actually will stimulate both beta and dopamine receptors that actually put a squeeze down on the vessel. And oftentimes you're going to find these in the ICU. So these are all given through an intravenous, usually a central line access. That would be dobutamine, epinephrine, norepinephrine, dopamine. Again, these are in your critical care situations where we're dealing with sepsis. And I have a whole video on sepsis, so I'm not going to go too deep into the vasopressors, but they actually cause lots of constriction in order to clamp down to increase blood pressure. Next, we have our diuretics. Oftentimes what you'll find is that patients have to be a little bit on blood pressure medicine and a little bit on diuretics. And what happens with the diuretic is it actually reduces the overall blood volume. And when we reduce blood volume, we thereby reduce blood pressure as well. And so sodium as well as water are blocked in their reabsorption, and then it's excreted through the kidneys. Now, the big thing with this is they deplete potassium. So we have to be very, very, very careful about potassium and diuretics. So furosemide, hydrochlorothiazide, those are your two more common ones. And again, please be careful of those electrolytes. That's that safety question that comes at you from nursing school, okay? The other thing here is that these will be combined with an ACE inhibitor sometimes. And if you recall from just a few slides ago, just a few minutes ago, the ACE inhibitor actually causes hyperkalemia and the diuretic causes a loss of potassium. So oftentimes you will see a low dose of both of these used together. So an ACE like April and furosemide or HCTZ, very common here in Eastern North Carolina. Not sure where you're watching from, but you may see a different medication used, but they can use a low dose of both of these, and therefore it kind of levels out the potassium effect while lowering the blood pressure. Antidysrhythmics, this is if there's an actual electrical conduction problem in the heart. And so what it works to do is to fix that cardiac irregularity or electrical irregularity. They directly block electrolytes that affect the conduction system. So more specifically, we have that sodium potassium pump, also that calcium, or again, the beta blockers. And so oftentimes, I mentioned these earlier and before, that's the same thing, sorry. So it's classified as calcium channel blockers, those potassium activators, or beta blockers. Beta blockers we talked about already. Calcium channel blockers, common ones are verapamil, nifedipine, and diltiazem. Again, first line for blood pressure are going to be those betas, ACEs, and ARBs. Calcium channel blockers is more reserved for your pulmonary hypertension, which again is a more advanced perfusion concept. Next we have is the cardiac glycoside. This will actually lower heart rate and it will reduce cardiac output. And so oftentimes these are called a positive inotrope or positive inotropic effects. So cardiac glycoside will work in a couple of different ways. It is primarily used to treat heart failure. The most common one is called digoxin. A lot of you may have heard of that already. The thing about digoxin is it actually has a very narrow window of what we call therapeutic. And so that 0.8 to 2.0, again, I've said this in my lab talks. If you've watched any of the lab videos, this is subject to change depending on the facility that you work at, but it's not going to change that much. You see, it's very narrow as it is. And toxicity typically comes at a level greater than 2.4. And how do we identify it? So we find that confusion, weight loss, nausea, vomiting, diarrhea, loss of appetite, and changes in vision. They often will describe like yellow or green halos around the light. That is your aha that this patient may be experiencing digoxin toxicity, especially if it says something in your question about digoxin. The other thing with this is it will actually cause a fatal heart rhythm when it's toxic. So it will slow the heart rate down so much so that it causes a very slow and irregular rhythm. So we have to be very careful about that. And then hyperkalemia tends to happen in the face of dig toxicity. So you may notice too that your patient's potassium level rises to 5 or 5.1, 5.2 on up and up and up, because there is a direct correlation between too much digoxin and holding on to potassium. Next, we have our anticoagulants. So again, these prevent blood clots somewhere in the clotting cascade in order to reduce or suppress the amount of fibrin that is produced. And this is either to prevent or treat a deep vein thrombosis. And so our two primary examples are going to be heparin, which is typically used in the inpatient setting. And then we also have warfarin, which is also known as Coumadin. It's the same drug, and that's used more as a PO oral medication that's used on an outpatient basis. And so what you'll find is preventative for a blood clot is a heparin injection. Some of you may be familiar with heparin. Some of you may be familiar with Lovenox. Lovenox is just a form of heparin. It's just called a low molecular weight heparin, okay? It has to do with chemistry for all you chemistry buffs. But IV heparin, when we titrate a drip, when we're on a heparin drip, that is specifically for an acute, right now I have a deep vein thrombosis. So when we're on IV heparin, there's a couple of things we need to know. Number one, heparin is by itself. We do not use heparin. We do not mix heparin. We do not do other drips with heparin. Heparin goes in a line all by itself, dedicated by itself. The other thing is we draw APTT levels, okay? And when your patient is on heparin, they should be a therapeutic range, right? Because we want them to clot less and bleed a little easier. So we want it to be 1.5 to 2 times the normal PTT level. Normal PTT, 30 to 40 seconds. So again, 1.5 to 2 times that range is about where we want to be. Most of the time when you're in a hospital and your patient is on a heparin drip, you have standard orders. These standard orders will tell you if heparin, or sorry, if APTT level is between 35 and 40, go up on the heparin drip by such and such amount. So you have standard orders to kind of titrate this medication up or down depending on your patient's APTT level. The other thing that's important to remember is that the antidote or the reversal agent for too much heparin is protamine sulfate. That is a common NCLEX question. You may or may not see it in nursing school, but you will most likely see something similar to this, either in your senior level, last semester, or on the NCLEX. The next one we have is warfarin. And again, this is more of an outpatient treatment, outpatient maintenance. Maybe your patient's had a heart attack, they're at risk for another blood clot, they've had a stroke, they're at risk for another blood clot, or they have artificial heart valves, can also push you at risk for blood clots. So the deal with warfarin is it has multiple food and drug interactions. And the primary one that we're concerned about kind of on your first initial level of perfusion is going to be vitamin K. So the antidote to warfarin or the reversal agent is vitamin K. Where do we find vitamin K? Most common in our diets. Okay, so we have our green leafy vegetables, broccoli, spinach, cabbages, lettuces, all different types of green leafies are actually should be avoided when your patient is on warfarin because it can actually block the effects of warfarin. Also has a lot of drug interactions too, but really the most common nursing type question is going to be that vitamin K. INR is the blood work that we use. Heparin is the APTT level. Warfarin we use an INR level, which is an international normalized ratio. Sorry, couldn't think of the N for there for a second, but it's international normalized ratio. And that particular number should be measured for therapeutic levels of warfarin. And so to be considered therapeutic, that number should be between 2 and 3. And that's just the general rule for that. Next, we have antiplatelets. These actually keep the platelets from sticking together in order to form clots. Most commonly, we use these to prevent arterial thrombosis. And we have two major categories that go here. We have the glycoprotein platelet inhibitor, which is tirofibam, abiximab, and argatroban. Don't foresee that being on the test. Platelet aggregation inhibitors, aspirin at very high doses. We're not talking about the 81 milligrams of aspirin. We're talking about 325 or 650. And then the ticagrelor. The most common one that I'm familiar with are the agatrobans, because again, typically this is for an arterial thrombosis. Oftentimes we use these in a drip situation. Otherwise, we go back to things like Plavix or warfarin, things of that nature. A thrombolytic actually breaks up a clot by breaking down the fibrin. So it actually tears away at the fibrin within that clot. Now, these are used in very serious situations. We've had a significant disruption in blood flow. I've seen these immediately after a heart attack in the acute stage, like in the first couple of hours after a heart attack. I have seen these when there is a thrombolytic stroke, which means there is a blood clot in the brain causing a stroke. Also called an embolic stroke. You may hear the word embolic or thrombolytic stroke. There is also a potential for the carotids being clogged off, which again lacks perfusion to the brain. Heart attack lacks perfusion to the heart. So anything that's acute and life-threatening, you will find that these patients will be on this thrombolytic therapy. Pulmonary emboli. I've actually had patients in the ICU on TPA or tissue plasminogen activator when they have pulmonary emboli, because that is life-threatening, right? A clot in the lungs is life-threatening. Other examples are going to be alteplase, urokinase, streptokinase. I don't know if you've noticed this, but the ACEs, alteplase, urokinase, streptokinase, those are going to be your kind of clue and indicators that this is a thrombolytic. The biggest thing for this is we have to monitor for bleeding So some sort of sign of internal or external bleeding. External's easy, right? You see the hemorrhaging happen. Internal is a little tricky. If we're worried about the brain, we're going to check for mental status changes. If we're worried about the abdomen, we're going to worry about a GI bleed, which you may see as bright red blood or you may see as dark stools, melanin type stools, if you will. You may see blood in the urine. Those would be indicators that there is some sort of hemorrhaging taking place internally. Lastly, we have lipid lowering agents, also known as anti-lipemics or cholesterol lowering meds. They actually specifically work in the liver. I know most drugs are metabolized in the liver, and this one is too, but it also works directly in the liver to block the synthesis of cholesterol. So it tells the liver, no, 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 stop converting that to cholesterol. So it'll result in a decrease in total cholesterol as well as total lipids. These examples are your statins. This is probably the most common terminology for them. There's another name like COMGHA reductase inhibitors, much easier to remember statins. Atorvastatin, pravastatin, simvastatin, probably the most common ones. The biggest thing with these drugs from a nursing perspective, again, is to monitor liver function tests. So we want to be careful of how it impacts the liver. And then we also have to worry about muscle pain, muscle weakness, changes in strength, because it can actually cause a condition called rhabdomyolysis. But again, that's more of an advanced concept, so we won't go in that today. All right. And so hopefully that was short and sweet, down and dirty, gave you a quick overview of these meds. Again, that is basically what you need for a basic level perfusion. Okay, as we get more advanced, I have some ICU concepts that you can look at. But for now, especially if you are a first level nursing student, this will get you started. All right, drop any questions that you have in the comments. Please let me know if you're okay. If you like this content, if you want more of this content, make sure you like and subscribe, and I will see you guys in the next episode.